A phakic intraocular lens, PIOL, is a special kind of intraocular lens that is implanted surgically into the eye to correct myopia, nearsightedness. It is called phakic because the eye's natural lens is left untouched. This is in contrast to intraocular lenses that are implanted into eyes after the eye's natural lens has been removed during cataract surgery. Phakic intraocular lenses are indicated for patients with high refractive errors when the usual laser options for surgical correction, LASIK and PRK, are contraindicated. Phakic IOLs are designed to correct high myopia ranging from 5 to 20D if the patient has enough anterior chamber depth, ACD, of at least 3 mm. Three types of phakic IOLs are available: angle-supported, iris-fixated, implantable Collamer lens. Medical uses. LASIK can correct myopia up to -12 to -14D. The higher the intended correction, the thinner and flatter the cornea will be postoperatively. For LASIK surgery, one has to preserve a safe residual stromal bed of at least 250 m, preferably 300 m. Beyond these limits there is an increased risk of developing corneal ectasia, i.e. corneal forward bulging, due to thin residual stromal bed, which results in loss of visual quality. Due to the risk of higher order aberrations, there is a current trend toward reducing the upper limits of LASIK and PRK to around -8 to -10D. Phakic intraocular lenses are safer than excimer laser surgery for those with significant myopia. Phakic intraocular lenses are contraindicated in patients who do not have a stable refraction for at least 6 months or are 21 years of age or younger. Pre-existing eye disorders such as uveitis are another contraindication. Although PIOLs for hyperopia are being investigated, there is less enthusiasm for these lenses because the anterior chamber tends to be shallower than in myopic patients. A hyperopic model ICL, posterior chamber PIOL, is available. Corneal endothelial cell count less than 2000 to 2500 cells/mm. Superscript 2 is a relative contraindication for PIOL implantation. Advantages. PIOLs have the advantage of treating a much larger range of myopic and hyperopic refractive errors than can be safely and effectively treated with corneal refractive surgery. The skills required for insertion are, with a few exceptions, similar to those used in cataract surgery. The equipment is significantly less expensive than an excimer laser and is similar to that used for cataract surgery. In addition, the PIOL is removable, therefore, the refractive effect should theoretically be reversible. However, any intervening damage caused by the PIOL would most likely be permanent. When compared with clear lens extraction, or refractive lens exchange, the PIOL has the advantage of preserving natural accommodation and may have a lower risk of postoperative retinal detachment because of the preservation of the crystalline lens and minimal vitreous destabilization. Disadvantages. PIOL insertion is an intraocular procedure. With all surgeries there are associated risks. In addition, each PIOL style has its own set of associated risks. In the case of PIOLs made of polymethyl methacrylate, PMMA, surgical insertion requires a larger incision, which may result in postoperative astigmatism. By comparison, PIOLs made of Collamer, a foldable gel-like substance, requires a very small incision due to the flexibility of the material and thus significantly reduces astigmatism risk. In the cases where refractive outcomes are not optimal, LASIK can be used for fine-tuning. If a patient eventually develops a visually significant cataract, the PIOL will have to be explanted at the time of cataract surgery, possibly through a larger than usual incision. Another concern is progressive shallowing of the anterior chamber, which normally occurs with advancing age due to the growth of the eye's natural lens. Multiple studies have shown a 12 to 17 m/year decrease in the anterior chamber depth with aging. If a phakic IOL patient is assumed to have a 50-year lifespan, the overall decline in ACD may add up to 0.6 to 0.85 mm. Long-term data about this effect are not available. This concern is more important in ICL because it is implanted in the narrowest part of the anterior segment. Complications. Glare and halos, which may cause nighttime symptoms especially in patients with larger pupil diameters. Cataract, which is the most crucial concern for the sulcus-supported PIOLs. According to FDA, approximately 6% to 7% of eyes develop anterior subcapsular opacities at 7+ years following implantable Collamer lens implantation and 1% to 2% progress to clinically significant cataract during the same period, especially very high myopes and older patients. Endothelial cell loss, especially for the anterior chamber pyols. A study observed a continual steady loss of endothelial cells of -1.8% per year. Pigment dispersion may be seen in iris-fixated and sulcus-supported pyols due to iris abrasion during pupillary movement. Other complications include glaucoma and pyol dislocation or decent ration. Preoperative evaluation. Anterior chamber depth, ACD, i.e. the distance between the crystalline lens and cornea including the corneal thickness, is required before the surgery and measured with the use of ultrasound. Iris-fixated IOLs are fixated to iris, therefore they have the advantage of being one size, 8.5 mm. Sulcus-supported IOLs need to be implanted in the ciliary sulcus, which may have various diameters among individuals, therefore anterior chamber diameter needs to be measured with a caliper or with the use of eye imaging instruments such as orbscan and high-frequency ultrasound. A caliper and orbscan measure the external limbus to limbus diameter of anterior chamber, white to white diameter, which provides an approximate estimation of AC diameter, but UBM and OCT offer a more adequate measurement of the sulcus diameter, sulcus to sulcus diameter, and should be used when available. Surgical technique. The artisan, varicis, lens is implanted under pharmacological meiosis. After creating proper incision, the lens is grasped with curved holding forceps and inserted. Once in the anterior chamber and while firmly holding the lens with forceps, temporal and nasal iris tissue is enclavated with a special needle. The operation is completed with an iridectomy and the incision insutured. The ICL is implanted under pharmacological mydriasis and implanted in the retropupillae position, between the eye's iris and the crystalline lens, using cartridge injector or forceps. Both eyes can usually be done on the same day. Steroid antibiotic eye drops are usually prescribed for 2-4 weeks after surgery. Regular follow-ups are recommended.
Please subscribe and thanks for watching.